My name is Marat Fudim. I'm a cardiologist at Duke, a heart failure specialist, and I lead our heart failure remote monitoring clinic. And I'm happy to have this in-person meeting and to see so many in person for the first time in a while. I am excited to be joined by Larry Allen and Andrew Sauer, who I'll introduce you in a second. The topic of this industry expert theater by the HFSA is HeartLogic, clinical data and integration into clinical practice. Larry Allen is the Vice Clinical Chief at the University of Colorado, has participated in a number of clinical trials, and is also on the steering committee for the MANAGE-HF study, which he will present some of the data for. The Andrew Sauer here on the right is from Kansas University, and he is a former heart failure director and has participated in a number of remote monitoring studies and heart failure studies in general. I will kick off the discussion by talking about HeartLogic, what it really is made of, and give you some clinical pearls from the clinical practice. And this will be expanded upon by my colleagues here. These are my disclosures. So one good thing that I think came out of the COVID crisis was that it led to an acceleration of the telehealth transformation. This is true for our institution, but many other institutions which have introduced remote monitoring technologies overnight, it seems. And on the right side, what I'm showing is the actual daily telephone visits, and separate from that are the video visits that we introduced in the Duke Health system in a matter of days that went from 0 to many thousands. And in the case of our institution at least, remote monitoring visits will remain the standard of care for at least 20 to 30% of the patients. This, of course, will only be augmented by objective metrics such as some of the technologies we'll be discussing here today. Cardiac decompensation does never happen overnight, and we know well from data that I will not be showing you that if you rely on signs and symptoms such as weight gain or shortness of breath, you will be often very late in the cascade of cardiac decompensation and might not be able to catch the disease process and intervene upon successfully. So we know we have to go upstream prior to a cardiac decompensation episode to be able to prevent that cardiac decompensation. And to do so, you need to often act on multiple parameters and or highly sensitive biomarkers, which often we cannot obtain unless we have technologies that I'll be addressing here in a second. We believe, or at least I believe, that to date, technology is no longer presenting a limitation to the management of patients on a remote basis. What I believe is that synthesizing this data, presenting it to clinician, and transferring into actionable data is really where the limitation is to date that has slowed down remote monitoring integration into clinical practice. But again, technology has been there for a while. It has riped to be ready to be used in clinical practice. And I think what we want to show you here today a little bit is how we integrate it into clinical practice, and Andrew Sauer will give us a lot of examples from the real world setting. So what makes a good remote monitoring system? I just showed you a number of FDA-approved products. I could have given you 5 more slides of those. And I think what makes a good remote monitoring solution is that if it is sensitive to cardiac decompensation. You want to be timely in your discovery that something might be going on. You want to be specific to heart failure. You don't want to have too many false alerts. You want to know that if something is happening, it's most likely going to be cardiac in nature. You probably want to be a multi-sensor technology, and why I say that is that because heart failure is a multi-syndrome disease. There's not one thing that's going wrong. It's not just fluid accumulation. There's a lot of vital sign abnormalities, so you'd want to stand on many broad feet to try to capture multiple decompensating processes at a time. Probably one of the more important points is that the information provided by the technology needs to be easily digestible, not only to the clinician, but also to the patient. And final and most important point, that data needs to be actionable. Data that is not used is worthless. Data is not going to help the patient stay out of the hospital if it's not acted upon. So what does HeartLogic integrate? HeartLogic is a software program uploaded on implantable Boston Scientific devices. That software package is combining a multitude of sensors, specifically 5. S1 and S3 are heart sounds like we learned in med school, but they are obtained slightly different. The RV lead that's drilled into the RV apex or the septum is able to sense through a specific methodology the strain on the heart muscle. So I think of S1 and S3 if there's a strain on the cardiac muscle. The respiratory rate is obtained through the change in conductance across the heart and the lungs. It measures the thoracic impedance, that is another term for fluid accumulation on the lungs. And finally, the activity level. The most important part here is that each individual component has been validated in separate studies as an independent predictor of cardiac decompensation and is associated with heart outcomes. But now they're combined. So the Multisense study was a study that was led by John Boehmer and not published too long ago. And it found that there's a sweet spot at which time point, and this sweet spot is a HeartLogic score that combines all of those individual sensors. It gives you a unitless value. And if you land around the 16 and your score climbs beyond 16, you have a very high sensitivity that something is going to happen that is heart failure related. The good thing about this technology, and very unique, is that you have in average 34 days prior to an actual adjudicated event or heart failure hospitalization. So this technology is so sensitive that it's over a month upstream in average prior to the cardiac decompensation. So you have time to act, unlike if you rely on heart failure symptoms reported by the patient and weight gain. The unexplained event rate was relatively low. So this is one of my final slides to talk about the technology itself, is that, if you are in HeartLogic alert status, 16 or greater, compared to a patient who is not in HeartLogic alert status, what does that mean risk-wise? Well, it means that you have a 10 times higher risk you're going to be hospitalized in the upcoming 1 to 2 months. You can augment this by additional biomarkers. Nobody says you shouldn't augment device-based strategies by additional biomarkers, clinical acumen, calling the patient. But if you simply add NT-proBNP and you have a high HeartLogic alert status and you have a high NT-proBNP, compared to neither of those, now your risk jumped 50 times higher. So I'm going to give you some examples from my clinical practice that I lead with one of our heart failure remote monitoring nurses. This was one of the first patients, and it was actually a very interesting story. The pandemic started, we transitioned to remote monitoring clinic. There was the impetus for us to switch to HeartLogic remote monitoring. And this patient, I call him up because he was in alert status. He was around 20, 30 mark. And I call him up and he tells me he's just fine. I always semi-jokingly say that's why I don't transplant unmarried men, because I asked to talk to his wife. I talked to his wife and he tells me, no, he has been puffing. He has been committing himself to the couch. So I asked this man to be seen by a heart failure provider. Turns out he was quite sick. He got a right catheterization, got admitted because he was in cardiogenic shock without knowing about it. He was lingering at home without knowledge of it. And this man ended up getting transplanted within 3 months of the initial alert. So it's sort of a success story where a patient would have been otherwise in a free without our knowledge of being in heart failure. So this is another way we use our HeartLogic score. So this patient ended up getting a HeartLogic score, which the 0, and I sort of skipped a little bit, I excuse myself. The HeartLogic score is displayed for each individual component of the score in these 5 bars. The black bar means the score is rising due to this individual component. Individual components are also displayed longitudinally throughout the course of the last 1, 2, 3 months. This can be set up selectively. And the combination of all of that is displayed in that single score. Once it rises above 16, that's a positive score. So you can sort of choose and pick whether you want to have it dumped down to a single score and just rely on that, which is what we do in most cases. But if you are interested and you want to go into the details and you want to look into the trends, well, then you can display what I'm showing you at the bottom here. So this particular patient, the 0 refers to the status all the way to the right of the screen. At the height, he was around 30. This man ended up getting hospitalized. We were not able to manage him at home. We knew that he's in heart failure. We sent him to the hospital. He's getting diaresis and his score is coming down to 0 prior to discharge. So we know we established a new baseline for this man. When he was dry, he was discharged, he was around 0. Well, this man then suddenly started rising again on HeartLogic scores. So here we preemptively started giving him IV diuretics on an outpatient basis. Despite reaching a very high congestive score, we were able to keep this man out of the hospital simply by shuffling him into our same-day access clinic, give him IV diuretics, and he stayed out of the hospital. Another way you can utilize the Boston Scientific HeartLogic data is that it actually provides you additional data points on the rhythm abnormalities. So this is an extra. You don't have to utilize it if you want to, but it has a lot of useful information that if you spend time, you might actually gain a lot of valuable information. I'm curious to hear what our colleagues here, if they use that as well. So it gives you the ATAF, so atrial fibrillation, atrial tachycardia burden, ventricular therapies if they were applied. So this is an equivalent of AFib in our heart failure population. So when they go into AFib, you know it. And in this patient, he went into HeartLogic alert status. He crossed the threshold of 16. We looked what happens. After he went into alert status, he flipped a few weeks into AFib. We see that commonly. Once your heart gets stretched, you go into AFib. What happened with this man, he was shuffled into the emergency room. He got cardioverted in the emergency room and sent home from there. His score is improving. He's out of AFib. There's no AFib burden here. He goes out of AFib and flips back into AFib now, and that's now driving the score. So in that case, this man was told, listen, we now see again that you're back in AFib, your score is rising, let's get you to an AFib ablation. So this man was managed entirely remotely with minimal touch points with medical care, and were able to identify the rhythm problem as a driver of his decompensation, which of course this man was otherwise not known that he's in AFib. Also, we use patients to monitor and guide the guideline of medical therapy following an acute event. So when we know this patient was hospitalized with a high score in the 30s, we decongest him in a hospital setting through the initiation of inotropes. Well, I wanted to get this man off inotropes and get him on GDMT. I would love to see my patients every day in clinic. I can't. We don't have the ability to do that. Particularly inotropic patients, we want to keep a close eye on them. So this man was seen every 2 weeks, augmented by serial looks with HeartLogic. And as long as he was trending down, I was feeling comfortable that I could sequentially wean the inotrope. We ended up weaning him of inotropes, and he was out of the HeartLogic entirely to the right of here that I'm not showing. But this gave me the confidence to spread out a little bit my looks on that patient because I had objective data on him while he was at home. Last but not least, it sounds like I keep ringing the alarm bells every time, HeartLogic, you need to act. Well, you can use it the other way around as well. This was an LVAD patient. Technology works in LVAD in our experience as well. Curious about your experience. This patient was short of breath and having chest pain, young man with a left ventricular assist device, LVAD. So we actually looked at the HeartLogic score because he was not willing to drive that distance to come to clinic, and his score was low. What we told him, listen, your score today is low. The objective medics do not suggest that your heart rate, your respiratory rate goes up. Why don't we keep watching you? We were able to triage this man remotely, and we're avoiding him going to the emergency room, which might have been an unnecessary event. And it ended up not going to the ER. He ended up having just fine. We suspect it was a chest pain episode due to anxiety episodes. That's all from my end. Thank you very much. And now to Larry Allen.
Thanks, Marat. So Marat nicely laid out what HeartLogic is and how the score is made from these different parameters that come from the device. And the Multisense study effectively looked at how that scoring system correlated with events, what the relationship was in time. So it tells us that we have a score that's correlated with an event, but it doesn't tell us what to do with the score. So we move from Multisense to the multiple cardiac sensors for management of heart failure, the MANAGE-HF study, which was conducted over the last few years and was presented at the ESC Heart Failure Conference by Adrian Hernandez. And what I'm going to go through is go through the MANAGE study itself and show you how the alerts played out in real practice and how we tried to use the alerts to have behavior change and clinical change in management to see what happens to patients. So this has also already been nicely laid out, but our patients obviously have heart failure. It's an undulating disease. We want to follow them over time, and we'd like to be proactive with our management rather than reactive. Unfortunately, most heart failure management is reactive. We wait too long, or we wait until people get in the hospital. 70% of the costs are spent there. We went through this as well. There's the 5 different sensors that come together to create the HeartLogic score. As was stated, the patients, when their score goes and hits 16, they go into alert. And so an alert is created that then is transmitted automatically to the clinical team that's monitoring the device. And then they stay in alert until that score comes all the way down and goes below 6. And once it's below 6, then patients are out of alert at that point. I think sometimes people think that a patient, they get an alert and then that's it. It actually tends to last over weeks that patients are being managed. And then again, the question is, what are you going to do with that? And then does that make people's outcomes better? And so Manage is really designed to test an alert management guide in response to these alerts, and then in an exploratory analysis, see if it seems to lower event rates when we do that. So the Manage heart failure study design, the objective was to assess the clinical integration and safety of HeartLogic multisensory index and alerts in clinical practice. This was a prospective, single-arm, non-randomized, multi-center, open-label, FDA-mandated post-approval study. So many of you probably use HeartLogic. It's out there. It's approved. The question is, how do we, even though you have it, how do we help people use it better? There were 191 patients who were enrolled in the study prospectively, and at the end of the day, there were 30 sites that agreed to participate. 27 of these were across the United States, and there were 2 in France and 1 in Germany. So in order for patients to get into the study, other than having to have a Boston Scientific device that's equipped with HeartLogic sensors and software, patients had to have symptomatic heart failure, being New York Heart Association functional class 2 or 3 at the time that they were enrolled. And then they had to meet one of the following 3 conditions. Either that they had a documented hospitalization with a primary diagnosis of worsening heart failure in the year prior to enrollment, or an unscheduled outpatient visit with IV diuretic therapy for worsening heart failure in the 3 months prior to enrollment, or an NT-proBNP greater than 600 or a BNP greater than 150 in the days prior, or the 3 months or 90 days prior to enrollment. And I think the goal there is that HeartLogic probably is going to be most helpful in your patients who are ambulatory but symptomatic, at risk for decompensation. I think, with any of these management tools, if you have somebody who's incredibly stable and not symptomatic, you have a device that you're monitoring, probably not going to tell you much. The other side of the equation is if you have patients who are class D and failing, in many ways, there's not much more that you can do for them. So you know that they're at risk, but a lot of times you need to move to a totally different strategy. So patients they were enrolled, and then there was kind of a baseline period where they collected baseline data, and then patients were monitored just using routine clinical care. So if I said I needed to see them in a month, then they came back in a month. If I said they're doing well, I'll see you in 6 months, then they came back in 6 months to see me. All patients were asked to be seen at least every 6 months. Providers, again, received the automated notice when an initial HeartLogic alert occurred, and they got weekly re-alerts until patients again came out of threshold, dropped below 6. And then the key of the managed study is the alert management guide that kind of suggests when you have a patient that goes into alert, these are the things that you should consider. So essentially the alert management guide in action, you have a patient who's below 16 on their device, and then at the yellow, or the blue dot with the yellow on it, the patient goes over 16 and you get an alert, and it says you should escalate treatment. And essentially there were 3 options for escalating treatment. The first was to decongest the patient, so increase the diuretic approach that you're using. The second was to increase guideline-directed medical therapies or vasodilator therapies to treat heart failure. And the third was to treat other exacerbating issues that you might identify. So those could be like atrial fibrillation. Another key aspect of this is also to follow up on adherence, because some of this, you call the patient and realize there's some issues with their medications, and that would be a qualifying treatment as well. Then again, most patients actually stayed in alert for more than a week. So you would get another alert, and if the score was not decreasing, then you had to further escalate treatment, whereas if the score was decreasing, even if you were still in alert, then you could repeat or continue the therapy that you had started the week before. So these are some examples. I think Marat somewhat covered this, but a patient, the dark blue line is the patient's score is increasing. They cross threshold, so you double the diuretics. And if they improve, great. If they don't, then you may think about transitioning to an ARNI, adding SGLT2 inhibitor if you had not, or adding a vasodilator if the blood pressure is high. If that didn't work, then another option was to add metolazone to their management. So this is just some kind of examples of how therapy gets escalated over time to a score that keeps going up, up, up. So these are the baseline characteristics of the 191 patients. They were 67 years old on average, 68% male, 81% white, non-Hispanic. About half the patients were ischemic, and another 40% were idiopathic or dilated cardiomyopathy. And then comorbidities were in kind of the 7 to 15% range for COPD, pulmonary hypertension, peripheral vascular disease, and cerebrovascular disease. Patients all had a defibrillator, so not surprisingly, their ejection fraction was low at an average of 26%. The NT-proBNP median was 1,500, and they had mild kidney dysfunction. These patients 83% were already on a loop diuretic. Some had thiazide, and then the combination of ACE-ARB ARNI was about 80%. Spironolactone or eplerenone used 43%, and beta blockers in nearly all patients. Additional vasodilators in 18. So the results were that among those 191 patients, there were 585 alert episodes, okay? And those alert episodes could last for a while. And what we saw was 1,766 changes in heart failure medications over the follow-up period. And in 74% of the time that a patient was in alert, they had an augmentation in their therapy. So here is what the responses look like. So these are the 30 sites along the x-axis, and then these are the alerts at each site within the patients that they were managing. And the purple bars are that they had a change in their diuretics. The kind of bluish, light blue-green bars are a diuretic and a non-diuretic heart failure medication added, and then the yellow bars are that they only had non-diuretic medications changed. And you can see, looking at this, there's a fair amount of variation in the way that sites responded, both in terms of whether they responded and also what they did in response to those alerts. So this study, again, was non-randomized. It was a single arm. But among those patients who went into alert, if they did not receive a decongestive treatment while they were in alert in that first month, that's the red bar, and you can see that they were slower to recover. And those patients who went into alert and had increase in their decongestive treatments, they actually came out of alert more quickly. There was some concern initially that just responding to these alerts and doubling diuretics, you could put people into renal failure or actually cause trouble. So there was a pretty robust look at safety events, and there were only 5 site reported events, 1 for abnormal lab values, 2 for renal insufficiency, 1 for dizziness, and 1 for syncope. So in conclusion, HeartLogic multi-sensor index and alert algorithm management was safely implemented, so very few safety events. The results should be considered in the context of this single-arm study, which is of small size. The implementation was associated with heart failure treatment augmentation, so more treatment when people were looking at these alerts, and that resulted in more rapid reduction in the HeartLogic index values. And overall, the result provides evidence to further evaluate the role of HeartLogic in routine heart failure management. And I'll present some more details on the variation in treatment tomorrow at the late breaker. Thank you.
Thanks. Okay, so the stage has been set for why this might be able to help our patients. But the logistical challenges are real. And so how do you put this into practice practically? So I'm going to focus this on the sort of the context of remote monitoring program building in general, and how to really implement the technology. We have about 150 patients who we follow closely with HeartLogic, and over 200 patients with CardioMEMS implants. And so figuring out how to workflow that and handle that volume of alerts and data is really part of the trick, because you can do this a little bit, but once you start scaling this, you're going to run into a lot of challenge. So we'll talk a little bit about our experience with that. So tips for technology. So 8 steps. Define the mission. So you got to have a mission for any endeavor. Outline the best therapies, so you need to know what those are. Begin with home. You got to clean up your own house before you build an outreach strategy. And then you need to standardize the process. As you get a map out, you figure out where you're going to go as you grow your overall patient care population. And then you add the technology and workflow it, and really understand the economics and review with your business people, because you're building unfortunately, we live in an economic world where we have to think about the business of how we do this for patients. And then keep reflecting, revising, and repeating. So for us, when we came to Kansas in 2015, there was one VAD transplant program, really one comprehensive heart failure program in Kansas City, and we recognized it was probably underserving our population. So 70 VAD transplant cases, as fast forward to the last year, 140 VAD transplant cases in Kansas City. It reflects how potentially underserved Kansas was in particular. So we really said, our stake in the ground is going to be to take care of Kansans. And that should be for all patients. And really, if you can get a great therapy in Boston or Chicago, you should get that in Kansas, including rural Kansas and areas with disparities. So what are the best therapies? I'm not going through all this, but the point is, we know that there's been a revolution in medical therapies, particularly for reduced ejection fraction heart failure. There's a quick laundry list of the trials that are relevant. And we know that if we apply the best therapies, particularly sort of the 4 pillars, which now includes SGLT2 inhibitors, and angiotensin receptor blocker, neprilysin inhibitors, that we can reduce hard outcome events, mortality and hospitalizations, with a relative risk reduction of 80 to 90% when we apply these therapies. And Greg Fonarow does a great job harping on this on social media all the time to remind us, if we apply the best therapies, we're going to really see the needle change. HFpEF, preserved ejection fraction heart failure, is way less clear, but we're starting to see some signs of life as we look at SGLT2 inhibitors. As Emperor Preserved was presented at ESC, we see some really encouraging signs that we may have some therapies that can actually at least reduce hospitalizations, and hopefully we'll see some impact on harder outcomes going forward. But the problem is implementing therapies, there's lots of barriers. And so we had an ACC roundtable last fall where Michelle Kittleson talked about how there's really a lot of logistical barriers, paying for the therapy, staffing the teams that are going to do this. There's the logistical challenges of bricks and mortar. I mean, you can't just put a clinic up everywhere. How do you reach patients that are more remote locations, or maybe patients that can't do well with transportation? There's a paucity of experts. There's only so many heart failure experts. We can't see every patient. We need to be able to bridge the technology and education gaps with general cardiologists, primary care physicians, nurses, and that's going to be the way we reach these folks. COVID taught us something. You heard this earlier. COVID gave us an opportunity to revolutionize and really step on the gas when it comes to telemedicine opportunities. We went from basically having to do these very contrived remote monitoring, or telemedicine visits where a patient would drive to Hayes, Kansas, 4 hours away from us, and they'd have a video monitor, and we would interface with them, but there needed to be a nurse there, and the only way you could do a telemedicine visit was to do this system. But obviously when the national emergency was declared, CMS said, nope, you can do remote monitoring and you can do telemedicine. You can literally have an encounter with the patient sitting in their car. And so video visits and phone visits became supported and reimbursed. We've all seen the really innovative ideas out there of using nurse titrations, nurse-directed titrations over the phone, pharmacy titrations over the phone. Larry Allen presented at AHA some really interesting data on having patients use digital prompts to come to their clinic and essentially prompt us to initiate therapy escalation. So there's lots of innovative strategies outside of remote monitoring telemedicine that I think are coming to become opportunities. It is interesting to point out the disparities, though, and I'll be talking more about this afternoon in the virtual health session. There is a clear differentiation between patients who do video visits and telephone visits. So we know patients of color, elderly patients who are not real savvy with technology, they struggle with the video visits, and so they tend to default to phone. So we need to recognize that video visits may not be the solution for a lot of patients. And this is another paper highlighting this. Language barriers also tend to favor telephone over video visits. And so, the elderly population, they may not be as good at dealing with the technology that they need to download, whatever app that you use to do your telemedicine visits. So phone visits are still pretty powerful, but they are not armed with data. So can we arm them with data? Well, this is really where remote monitoring can really, as you've heard, augment the opportunity to intervene upstream. And we talked about this in a scientific statement paper that was out a couple weeks ago. And my charge on the writing committee was to focus on the section on what did we learn from COVID as it relates to heart failure, as it relates to using technology like telemedicine and remote monitoring. And again, really allows you to really get data in your interface with the patient. And then the televisit really allows you to get the narrative from the patient, assess the symptoms, and really do shared decision making. So why build a remote monitoring program? It's going to help you get hashtag GDMT works, a hashtag that we use a lot on social media to point out how to get like we talked about, the pillars of therapy that are so important and how to be more proactive. Getting access to the advanced heart failure team without having to see every patient in a heart failure clinic, getting upstream in the longitudinal continuum of heart failure, addressing disparities. I'm going to keep saying that because I really believe remote monitoring has opportunities for addressing disparities, and shared care. Shared care isn't just a buzz term for us, but we believe that we have to partner with general cardiologists in Wichita and Hayes, and not just expect that patients are going to come to Kansas City. It's just not practical. We can't do that. So telemedicine and remote monitoring allows you to build bridges and do shared care. Telemedicine has a shaky history, so here's a list of casualties of negative studies. And I'm not going to go through them all, but we've kind of heard about these. One glimmer of hope was a German study, TIM-HF2, where they looked at ECG device, blood pressure monitoring, and a scale and a pulse oximeter, and they actually moved the needle on hard outcomes like mortality by doing this aggressively. So that was encouraging. That was in Germany. It's a different system than the American system, obviously, so it's hard to really apply that, but it gives us the sense that this can be done. Obviously, we know about the Champion trial. This is now a decade old, but the real main impact was the ability to reduce hospitalization for heart failure with a relative risk reduction of 28%. Those are for class 3 patients. It was what Champion looked at. But we know from Champion data and other data, and that has come out in the last decade, that PA pressure reduction is something that comes with that remote monitoring data. One of the things that we've really been progressively moving toward, and you saw the variation that Larry presented in how sites manage the data that comes back. So whether that's elevated PA pressures or HeartLogic alerts, our first go-to is not necessarily adjusting loop diuretics. I think historically that's what a lot of us did, but now we have novel therapies that have diuretic-like effects, like SGLT2 inhibitors. Here's a good example of a patient who had a PA diastolic of 27, and just with initiation of dapagliflozin, we saw PA pressures drop. And this has been replicated in some clinical studies as well, to show that this is not just a single patient, but this is a real trend that can be observed in using SGLT2 inhibitors. The same is true for sacubitril valsartan. That data has been presented as well. So you don't necessarily have to augment their loop diuretics. You may be able to focus on, as you heard, GDMT escalation as an opportunity, which we know is better for our patients anyways. Preserved ejection fraction heart failure also, I think, has huge opportunities. When we realize there's not many great therapies for that population, we've seen in the Champion data, as well as post-marketing data, post-approval data, as well as in GUIDE, which we'll talk a little bit about, that this is a population that seems to really benefit from being able to understand their volume status and understand the remote PA pressure monitoring data. So GUIDE was just published and presented at ESC a few weeks ago. This was really looking at remote PA pressure monitoring, expanding to class 2 patients or patients who had not been hospitalized but had elevated natriuretic peptides. So this was the novel, endeavor to really expand the question. I mean, with less sick patients, can you still see a benefit? I'll point out that we still have a problem in clinical trials with enrolling patients that look like our patient populations. We still would like to see more patients of color and patients of female sex. But this is basically what the table 1 looked like, and you can see a significant proportion of class 2 patients, as well as patients who had not been hospitalized for heart failure, and they got into the study by just having elevated natriuretic peptides. So this is what's new about, if you're wondering what's new about GUIDE, this is what's new. The big challenge was COVID happened right basically in the fourth quarter of the game. So basically the national emergency was declared, and every single patient across the country was said, stay home. And then the follow-up continued, but 3/4 of the follow-up had already happened. And so this is what made the analysis a little bit challenging. And so a upfront analysis prospectively was designed, and the FDA and CMS basically asked the investigators to figure out how to address the data that came in, even though COVID had happened and impacted the data. So you've all heard the overall analysis was that this wasn't positive. The p-value was not significant. There wasn't a significant relative risk reduction. But in a pre-specified pre-COVID analysis, there was a near significant impact on the primary endpoint. And really the endpoint that was most notably impacted was the heart failure hospitalizations. And interesting, it's worth pointing out, the relative risk reduction is 28%, which is exactly the same relative risk reduction as we saw in Champion. Of course, this is a patient population that's less sick, so the absolute impact was maybe not as pronounced. And a lot of people, I think, have kind of spun this as a negative study. I actually think it's a positive study. I think that it's really important to recognize that COVID had a major impact, and Michael Zeil did a good job breaking down at the ESC meeting what happened to these patients in COVID. And the short version is basically COVID made everybody behave better. And that disproportionately impacted the control group, which was getting lots of encounters and lots of touches, way more than what would be conventional care. Remember, in the control group, patients were being contacted at a minimum of 1 time per month. We don't do that routinely for patients, especially outside of heart failure practices. So the other thing that I was really encouraged to see, we'll talk a little bit more about this afternoon, is patients of color and women seem to actually have a signal toward increased benefit. So again, wondering if maybe some of the disparity that we can address involves getting upstream and being more proactive with patients, and this actually favors patients who have been, in many ways, victims of bias, and ultimately we may not be as proactive with those patients naturally or conventionally. You've heard a lot about the HeartLogic sensors, so I'm not going to belabor this. I didn't intend to go into all this because these guys already did that. But the bottom line is you have 5 markers that you can follow. You can follow them individually, as you heard, but you can also follow them collectively and take advantage of the HeartLogic index. Again, what's novel about this is the S1, S3. And that's really what's different about this compared to other device monitoring. And the classic example I like to point out is, when you talk about thoracic impedance being down, which patient of these two actually has heart failure? Because there are things that can impact intrathoracic impedance other than heart failure. For example, COVID or acute lung injury. So obviously patient A not only has a drop in thoracic impedance, but has a change in the HeartLogic index, has an increase in S3, has a drop in S1, has a change in respiratory rate. So this starts to make much more of a compelling case that this is heart failure, whereas patient B maybe has pneumonia. So real-world data, this was before we got to hear from Larry about the Manage HF data, but there is some real-world data. The this Italian group points out, what did people do with the alerts? So a lot of these patients did have symptoms. 20% of patients had stopped their meds. So one of the things we do is just check with the patient, did they stop their meds and get them back on their meds? I mean, are they going off on a cruise and eating cruise food all the time? So sometimes you find that there are things other than medication interventions that you can adjust. So going back to us, you got to begin with home. So standardizing your process is something that we did 5 years ago. We got in a room, locked ourselves in a room for 2 days and said, how are we going to standardize how patients come through our hospital, come through our emergency room? How do they get to the clinic? And ultimately, how are we going to resource our teams in the ambulatory space so that we can grow and do more outreach and actually capture these patients and take good care of them? So getting out your protocols and whatever can be standardized, you should standardize. So you kind of take the, I have to rethink this and recreate a plan for patients. When you can standardize, that's always better. You got to get a map, look at your population. Wyandotte County, which is our county in our backyard, actually has the highest burden of heart failure of any county in our region, with food shortages and disparities, galore. And so figuring out how to target that, but also recognizing that we have to figure out how to work with Colorado to take care of the patients in Western Kansas, because they really don't have any heart failure people out there. And we can't just fly out there every time we want to. So we've basically expanded to a pretty significant number of sites, both bricks and mortar and virtually. And we started with 1,500 encounters as a group, and we've grown to 15,000 encounters annually as a collective team. This includes 6-7 heart failure cardiologists and 6-7 nurse practitioners. And we do fly to Hayes, but what's great about it is we fly to Hayes, but then in between those visits that we fly, we can actually do, basically remote monitoring and telemedicine visits. So this is actually me before COVID changed the game in telemedicine. This is me basically interfacing with a patient who's in Hayes in a follow-up visit, doing a video visit, and the nurse is there. And so this is the fun of what we get to do. And the patients really like this. But for med titrations and adjustment of medications remotely, it's a lot easier to do. Our workflow will obviously be revising, I think, as we learn lessons from Manage HF. But again, our workflow, which isn't necessarily everyone's workflow, is that we carve out the HeartLogic data from our EP folks. This took a little bit of finagling because the EP folks appropriately didn't necessarily want to have us in charge of remote monitoring, but they realized they didn't want to respond to the alerts, not these alerts. They wanted us to respond. So we carved those out, and Leslie, who's our lead coordinator sitting back there, could tell you all about how she did that. But basically, the data for HeartLogic alerts comes directly to her team. We have 3 nurses, well, 2 nurses now, we'll soon have a third, that do this. And this is kind of how we workflow it. And you can see it's a little bit more of a conservative approach. There's a lot of checking with the patient, making sure they're on the right meds, making sure their diet isn't wrong. And then we work toward, notifying the heart failure team member about maybe escalating GDMT or doing diuretic changes. But I think we're still learning how to best intervene. And I think when you look to the future, it's really exciting. So LuxDX Trends is, we're on pause right this second because we're working with the FDA, but the idea that you could actually implant a loop recorder type device, an ILR, and actually look to hopefully see HeartLogic data being built into that. So now we can think about expanding to preserved ejection fraction heart failure. So that's part of what we're looking at next. If you're interested in, by the way, participating as a site, let us know. We're still looking for more sites to get involved. So in summary, why build a heart failure remote monitoring program? One, it allows us to improve the pillars of therapies. It allows us to get upstream, allows us to be more proactive. It connects us to the patients. It allows us to address disparities, and allows us to genuinely participate in shared care. And so again, with the technology, you got to have a mission. Start with your why. Outline what the best therapies are. You got to know what those are. Where's the evidence for those? And you want to make sure we begin with cleaning up our own house before we try to do multiple sites elsewhere or try to work with the community in remote locations. Use a map. Think about the fact that you've got to create an economic model. I mean, how does this stuff get paid for? We pay for all of this through remote monitoring billing and through implant billing. So it ultimately supports Leslie and our team to do this work. But you have to be talking with your business people to do that. And I always say program building is team building. You got to have a good time and have a couple drinks to celebrate. We did a little bit of that last night. But the reality is, if you want to build programs, you got to be building people. And that's, really a big part of our story is how do we grow our people and to the people who take care of these very sick patients. So with that, I think we're finishing up just in time for questions.
Yes.
So.
Wow, what a session. Questions?
Can you speak to the parameters you need to titrate the drugs, which might be different than the ones that give you patient status?
Right, so this is a good question. We can address it amongst all 3 of us. What parameters matter in other ways? And parameters can matter to identify a patient at risk and whether you can titrate medications based on that same parameters. A composite might be something different. In my experience, and I've tried to demonstrate that by showing you different cases, it's clearly a risk factor identification, or somebody who's at risk, you need to act. So that's the primary intent of the HeartLogic score. That's how we use it. But we also use to manage patients in the post-hospitalization setting or in any acute setting to titrate medications and to inform us on negative trends. So that is, while not primarily intended for GDMT titration, I think is an inadvertent positive side effect of having key vital signs such as heart rate, respiratory rate, etc., that you can watch using the HeartLogic platform. But curious how you guys use it for GDMT titration.
Yeah, I mean, I think it's helpful to look at, okay, so the HeartLogic index is up, but what we try to do is we break down what's contributing to that to make sure it makes sense. So looking at the S3 and the S1, looking at the heart rate variability, and then if you are convinced, this is a heart failure event, and it's an upstream identifier of risk. The worst thing to do is to not do anything. The worst thing to do is to ignore it or turn off the alerts. Please don't do that. I mean, and that's happening. Part of that happens because we don't want to deal with the alerts, but we've seen enough data that really the debate is what should the intervention be, but I don't think we should be debating, should I respond to the alerts? The alerts are telling you your patient's in trouble, and if you wait, they're going to end up probably in the hospital or in your clinic saying, I'm full of fluid and please do something. So what we've learned is if, for example, the patient's not on sacubitril/valsartan, say they're on losartan, one of our first interventions might be to just switch them. And Larry's obviously pointed out to me in the past, he goes, why do we need HeartLogic to prompt us to do the right thing for these meds? And he's right. However, sometimes patients just haven't had that, maybe they're new to the clinic, maybe they're new to our program, and they're still on losartan, and then this just gives us an alert to say, you know what, rather than waiting till my follow-up visit 3 months from now, I'm going to go ahead and do the switch to sacubitril/valsartan today. Or, maybe we check the patient's insurance and their formulary and we can get them on dapagliflozin. And do that, but you got to watch, because it takes a week or two, as you heard, for the alerts to change. They're going to probably be where they are for the next week. That doesn't mean that your intervention's not working. It just takes a little bit of time to see those alerts go away. But it's okay to also address with loop diuretics. I just think sometimes we found that some of those patients that we hit too hard with loop diuretics, they end up orthostatic and their creatinine goes up, and so we're like, maybe we just want to be a little more gentle.
Agree.
I mean, I think that the alert itself usually doesn't tell you exactly what's going on. I think the alert tells you the patient's in trouble, and oftentimes you then need to have a conversation with the patient.
Yeah.
Wonderful. Any other questions? Yes, multiple.
I come from a kind of different background. I was doing heart failure in Atlanta and moved to Jackson, Mississippi, and now doing EP as a nurse practitioner. So had done HeartLogic in Atlanta, and when I saw that they had it, I was like, okay, this is a perfect role. What I'm finding, I'm in a large practice, there's 15 cardiologists. Patients will come in, I'll have an alert, I'll notify them of the alert, they'll look at them, they'll say they look euvolemic, send them home, not do anything. And I'm trying to get their buy-in, and I mean, I see it, and I see if I adjust medications, or like I had a patient that was just started on Mobic, and his numbers within like 4 days went up, and I'm like, called him, I'm like, what's new? He told me, I got him off, and it went right back down. It was like so simple. So I'm trying to explain that to them and get their buy-in, but I'm not seeing it with the general cardiologist. So.
Okay, so there is a lot to unpack. I think this is key that HeartLogic or remote monitoring to date is living in multiple domains, EP, heart failure, but majority of the patients are not managed by EP or heart failure, by cardiology. Answer number one is there needs to be a lot of education. We have dedicated email response sets when we reach out to providers. We have actually a little explanation what that means. You have to break down. You cannot simply send a HeartLogic score to somebody and say, you need to act. They don't know what that is. They don't know what the alert means. They don't know what the proper action is. So we actually get on calls with people in the beginning to do this education for people for the first time, second time, and then once they see the benefit, they tend to act on it properly. So I think it's a personal connection in the beginning. In the perfect world, you own all of it, right? You own all the patients, you own all the devices, all the technology. That's as unlikely in large practices that you own the entire patient cohort and you can take it out of the general practitioner's hand, cardiologist's hand. The second point that you actually mentioned, and this speaks to the false alert rate. In my practice, I'm curious what it's about you, I call it the natural course of disease. You have the HeartLogic alert goes up, which cause there is the cruise food. I'm curious to hear what that actually means. But people have exposure and they change that exposure, and it gets better without action. So in our practice, we wait for 1 week after the patient goes alert. Remember, we have 34 days on average. Where are we rushing? We wait for them and declare themselves that they continue to rise after 1 week. At the second week, because we're a Q1 base remote monitoring clinic, we will contact and sort of raise the bells, go to the individual providers and the patient. So I think, in my personal experience, give it a little time, see where you're heading, and if it's heading the wrong way, then act. And then you have less of those negative experience by a provider. Gotcha, I told you that it's not gonna work. The patient got better by himself, and patient's asymptomatic in most cases if you call him also too early. So I think there's a lot of experience you have to gain in this program, and Andrew told you about it. This is something you learn with time, but education, experience, and communication.
Yeah, I'd make 3 quick comments. One is, when you have a patient like that, there's almost always an opportunity to improve their care. I feel like we work really hard on guideline-directed medical therapy. I told Andrew, you should just be doing the right thing anyway. And when we ran our EPIC heart failure study, mostly with heart failure physicians and APPs, 99% of them had opportunities to improve their guideline-directed medical therapy. So there's always opportunities. That's the first comment. The second thing I would say is that I really think that the financial models have to change. Right? Like, people order an echo because it's lucrative, and they'll even put in a device and it's lucrative, but in getting people excited about working with their patients to follow them longitudinally, to act on alerts, that's not where people tend to make the most money. And so I think if you were at the plenary yesterday and listened to Rob Califf talk about the fact that we have an expensive system where, the sum is less than the parts, I think this is another example. The technology here is amazing. We have great practitioners. People really, I think, generally want to do the right thing, and yet we have a system that doesn't really work very well when you put all those parts together. I'd actually ask Andrew, what is the financial model that you've made for University of Kansas, especially once you get the devices in, to be able to have compensation?
Yeah, it's a tricky model because part of what makes our program work so well is we built it comprehensively for all remote monitoring technologies. So what feeds it is not just HeartLogic carve-outs, but also CardioMEMS. And so, but again, this is why I say begin with your mission. I mean, if you're committed to this, then you're going to figure out a way to resource it. So maybe for patients like this, or for colleagues where you're dealing with this, I don't want to deal with this alert. The other thing we learned from Multisense was the power of not being alerts. Being an alert is very important. You can basically risk stratify these patients as not necessarily needing your team. But then you can say, okay, but the ones that are an alert, please give us those patients, get them to our clinic, give us an opportunity to intervene. Because we just need to do the right thing. I mean, for example, the debate of whether a patient should be on sacubitril valsartan before getting a primary prevention defibrillator, it's interesting. If you ask us, we're all like, well, yeah, they should. I mean, we shouldn't just be putting defibrillators in patients who have an EF of 30% just because they've had that for 3 months. If they haven't been on best therapies, maybe they haven't been given the full chance to improve their ejection fraction. Then you'll hear people say, yeah, but they can't pay for the med. But then we pay for the device? I mean, it's kind of insane how we'll pay for the device as a system, but we won't pay for the med that will avoid the device in the first place, that they don't even need if they get the right therapies. So some of this just comes back to the moral courage to say we're going to do the right thing, and you have to get your administration and it comes with a lot of fighting, as Larry and I know. There's a lot of, honestly, you're going to fight about how to pay for stuff, but you have to be able to stand by and say, it's what's best for the patients. So to my EP colleagues, originally they were like, we don't want to give this data to you. I go, but we are the best team to manage these alerts. Give us the data. And eventually, Leslie negotiated with them. I don't know how she did it, but she pried it out. But we don't see all the alerts, and we don't see all of the heart rhythm alerts. And that's good, because I don't want to necessarily be managing all of the VT. So it's tough. Yes. Oh.
4 more minutes.
So how do you extrapolate what you learned from HeartLogic, CardioMEMS, with patients without ICDs or CRT, potentially with non-invasive monitoring, potentially setting up remote monitoring clinics with those patients? Do you think it's worthwhile, or?
So how do we, for people without any device? Sorry, Alex, I didn't quite get the question.
The question is basically, can you take what you learn from managing people with HeartLogic, CardioMEMS, et cetera? Is there a role to manage patients that don't have devices remotely, like on a regular basis?
Well, I think this is where we have the opportunity, and so we're looking at wearables, we're looking at other devices that can give us clues to really kind of take the lessons learned from multivariable monitoring. I mean, I think HeartLogic and Multisense really set the foundation for the idea that if we can find other parameters, even in a non-invasive way, we should learn from those opportunities. And you've heard, though, there's like 20 devices, you know, so I think you have to figure out which one you're going to pilot, which one you're going to pick. Are you going to investigate it, or are you going to just roll it out into practice? And so those are things we're working on. And I wouldn't tell you that we've got that figured out, but I think that's where we want to go.
Yeah, call it like a restaurant menu. Yeah, I think there's no one device that will work for every patient. There's a menu. Some already have implantable devices. Well, then go and use this. They don't have an implantable device. Think of patch-based versus CardioMEMS. I think it's going to be, as this grows, the reality is remote monitoring is here to stay. Patients love it. They love the fact that we can watch them remotely, that we can alert them in that 1 out of 100 events that something's going to happen and you're going to be it, let's act on it. So I think figuring out now how remote monitoring is going to work for your service center in 3 years from now is going to be crucial. If you don't figure it out, I think you're doing disservice to your patients. And what technology that is, that you'll figure it out along the way. But I think setting the infrastructure in place, as Andrew laid out nicely, is important.
Yeah, I mean, I would say a little bit different than Kansas. We don't have nearly as large of a program as Kansas, but we have kind of piloted some of it because it's coming, right? Like, I think patients are bringing more data. There's more physiologic monitoring available on watches and patches and all these other kinds of things. And so trying to figure out how to integrate that into the clinical workflow, but also what's the financial model for that? Just even, I think, you know, having 10 patients you try and figure out what to do with, I think at this point is pretty helpful for programs, because otherwise you're going to be way behind.
That's a really good point. The piloting things is a great way to get started in any business model that you're building. So for example, when we started CardioMEMS in 2015, we said, as a system, we'll do 15 and then we'll look at our data. We'll look at how it's impacting their quality of care, their safety. Are we having implant safety concerns, and are we able to justify this economically? And we've done the same with HeartLogic. We've done the same with other remote monitoring technology platforms, is pilot them, because you want to make sure that you don't throw all the money at it right now and then burn through your nursing resources. So it's a good way to do it.
The other thing is sign up for LuxDX as part of a study, because actually the way that we started doing and got some of our workflow around HeartLogic is we participated in the MANAGE study. We didn't have that many devices when we did it, but by participating in the study, it made me and our heart failure team have conversations with EP about how we were even going to do the study. Yep. And that's carried over now. Now we kind of look at the heart alerts from the different companies. That's integrated into our workflow separate from the study. So that's another way to think about kind of getting some momentum, is to participate in a randomized trial. And you're getting good data. Like, we need more data than just manage HF. We really need to know how to do this and how it changes outcomes.
Right.
Thank you everybody for that time. We're going to be around for a little bit for more questions. This was an awesome session. Thanks for your attendance.